So it's interesting, there was actually a study that came out from the CDC and it did a population estimate about how many people should be on PrEP, and that came out from the CDC last year. And it showed that approximately 1 out of every 4 young men who have sex with men should actually be on PrEP, and 1 out of every 5 intravenous drug users should be on PrEP. But more interesting than that, when you calculate the percentage of the heterosexual women, female population that should be on PrEP in the United States using that same article, and it didn't really focus on this, the numbers of women that are heterosexuals that should be on PrEP equal the number of young men who have sex with men that should be on PrEP. And it's a very, very large number. And so we're talking about a smaller proportion of the overall population, but we are talking about a very important cohort of people that are heterosexual women that should be on PrEP if they're having multiple different sex partners, if they're coming down with gonorrhea, chlamydia, or syphilis from their sexual activity. They clearly need additional protection, and so we need to address that. So I've actually spoken to a number of OBGYNs, and I've spoken to emergency departments also, because people are coming in for sexually transmitted infections, and the CDC and New York State both recommend that the act of having a sexually transmitted bacterial infection puts you at risk for obtaining higher risk of getting HIV and for being a candidate for PrEP. It's a behavioral thing. So the fact is, if you're having unprotected sex, enough that you can get a sexually transmitted infection, the likelihood is it's possible you can have another episode of having unprotected sex, and you could potentially acquire HIV. All of the recommendations right now are based on risk reduction modalities, based off of decreasing the rate of HIV that you could get based off of your existing behaviors. But there's also some new data that's starting to develop, and something that I'm seeing in my practice, of people that are not necessarily exhibiting high-risk behavior historically, which is what the guidelines are based on, but are anticipating going into an episode when they're going to be exhibiting high-risk behavior. People are planning to go to a music festival and have multiple different partners, or going on a cruise and are going to be with multiple different partners during a certain week or 2-month period of time, or 2-week period of time. And so those types of perceived risk that are not historical, but that are also something we need to look forward to, is something that I think additional research needs to be looked at to see how we can benefit the prevention of transmission of HIV through future perceived risk as well. The youngest patients that need PrEP are the youngest group that are having high-risk sex. In New York State, the current law is basically structured such that patients can receive PrEP over the age of 18 without parental consent. Under the age of 18, there's a determination that the doctor must make if the patient is going to be at higher risk of getting HIV based off of other situations, and so it's very variable. But it's important that there are some younger patients that do need PrEP, and with parental consent, they certainly can have PrEP. Or, depending on the laws of your region, you need to follow the advice of the local governance to be able to make sure you're providing the appropriate health care to prevent HIV risk. Some very difficult situations come up when you have a homeless, transgender male who is presenting that is having multiple different partners and is on the streets. But they're certainly a candidate for PrEP, but we need to make sure that they're receiving the best kind of health care they would need, instead of just being able to treat gonorrhea and chlamydia after the fact. We need to be able to prevent strategies as much as we can for those individuals that are having high-risk sex from being able to contract HIV. It is something we address, and it's something we work on a case-by-case basis and try to work with those individuals on an individual basis. And so we are working closely with the homeless shelters in our region and reaching out for other high-risk populations. And we just have actually opened a center for transgender health, and we're starting to work on that as well. I think there's always going to be some resistance. I think there's always some resistance to everything in medicine. I think that especially regarding sexual health, there's always going to be groups of people that are not in favor of certain perspectives. And so I think that there always will be some questions about what the long-term direction should be. You mentioned a specific drug, and I think that that's the drug that we have available through the FDA right now, but I think that it's not going to be very long before we have other medications that are available that have even lower side effect profiles and less medication problems for PrEP that will be easier routes of administration and less frequent dosing. There's quite a few in the pipeline right now. There's one that's available for treatment of HIV that's not indicated right now for prevention of HIV, but it's a similar group of medications, but it has a lower renal set of side effects. And there's other drugs that we spoke about that are the medications that are the injectable medications that you can be given, which they actually are going to start trials hopefully soon, taking a look at administering these medications once a month as a preventative for HIV. And those trials are still in very early development. I don't think that the manufacturer of the drug is doing a lot of direct-to-consumer advertising. I think they're letting the different health departments do that piece of the promotion. And I think New York City and New York State are doing a very good job of doing that. I'm not sure all municipalities and regions are doing as good of a job of promoting the drug. I think the drug company also is being able to support pharmaceutical studies and investigator-initiated studies and being able to do that. I think the real question is that where should the messaging come from that patients should take one pill once a day? And if that's for sexual health or prevention of HIV, or if that's from somewhere else regarding diabetes management, the real question is where is the best voice for that to come from? And in my perspective, I think those that are working in the health professions, in the public health departments, in physician offices, and as providers in academia are the best voice to be able to voice that rather than the drug companies themselves. And I don't know if the drug companies choosing to take a little bit more of a back seat rather than doing that, but I think there's some logic to that. I think that there's just different drugs, and I think that there's different perspectives that people are taking. Hep C, I think, is something that there's several different medications that became available at the same time that are competing for the marketplace. So I think that they're each trying to create that internal buzz about their individual drug, and I don't think we're seeing that same competition for HIV prevention methodologies that are available at this time anyway.